Number 10, something we do not see very often.
I can take this one, Dr. Gardner.
Okay.
That low power looks like we had a punch biopsy, and what's standing out are these large clear spaces, some of which have this sort of like feathery frost on a window pane type look. And that is usually a sign of the necrosis of lymphocytes that are sort of aggregating with their material together. Surrounding that, you have a giant cell reaction that's reacting to that. And in the right clinical context, I think this would be good for a subcutaneous fat necrosis of a newborn.
Very good. Yes. So we see fat necrosis often in dermatopathology, or really any type of pathology where you're looking at fat. Fat tends to necrose if it gets damaged. And what we usually see is the fat cells break down. We see foamy histiocytes and maybe some giant cells around it. But what we don't usually see is this pinkish, pink to purple. In this case, is mostly, usually they're eosinophilic, but in this case they look a little more bluish. But this kind of like radial, spiky crystals that are crystalline kind of pink material replacing the dead adipocytes, right? That is something that we do not usually see in regular fat necrosis. And so the reason for that, or one of the proposed reasons, is because this is from a baby, right? This is a newborn baby, and this is fat necrosis of subcutaneous fat necrosis of the newborn. And what happens is the fat, where it's not entirely clear why this happens. Some people have proposed that it has something to do with temperature, with a cold temperature leading to damage of the fat. And the proposed idea is that infants have a different lipid composition in their adipocytes than adults do, and they have more fatty acids that have that are, I think, saturated fatty acids with a higher melting point, and so that those fatty acids are thought to be more likely to crystallize and become solid if they get colder temperatures. So they're more sensitive to colder temperatures. That is one of the theories of why this could happen, but it's still, I think, basically considered to be idiopathic, but that's one theory about it. And I kind of like that theory because it does also explain why it looks so different, right? That the baby fat is different than grown-up fat. And so what you're getting is the lipids are crystallizing, and they make these kind of radial pink and white spiky structures inside the dead adipocytes, and then there's histiocytic and xanthomatous and giant cell reaction around it. So I can see here some nice foamy histiocytes. They've got bubbly cytoplasm, so they're eating up lipid also. I would say I have seen fat necrosis in a young child for a different reason. They had they were immune suppressed and had angioinvasive fungus. And they had fat necrosis because they were getting infarction of their skin from invasive fungi filling all the vessels. It was a horrible case. But they had a fat necrosis pattern that looked just like this. So I really like that idea that the fat is different in infants, and that's what produces this different pattern. Now, what is the one thing that I think has some overlap with this? And in my mind, I always have a hard time remembering how to tell these apart. And that's because it's kind of hard to tell them apart. But it's this disease, by the way, before we go on to that question, I did look up a few points on this. This is usually in the first few weeks after birth, and they're usually painless nodules that are symmetric. They're bilateral and symmetric usually, and they tend to be over the bony prominences. They could be the buttocks, the shoulders, the arms, the thighs, the cheek, and this process will usually resolve on its own within weeks to months. And for some reason, about 30 to 70% of these babies that have this have hypercalcemia. So they have increased calcium. They may have some other lab abnormalities as well. And again, it's not entirely known why this happens. Okay, so that's subcutaneous fat necrosis of the newborn. But what's the other disease that we need to make sure to not get this confused with, because it's much worse and is often fatal?
Is that sclerema neonatorum?
Yes, sclerema neonatorum. I have never seen a case of that in practice, but I'm always worried about it because it's a baby that's involved, and the mortality is like 70, 80, 90%, something like that. And that is a disease where you also get necrosis of the fat. The books say it is with necrosis of the fat with minimal inflammation, but I'd argue that other than histiocytes and giant cells, there's not a ton of inflammation here. There's a few neutrophils, but not a lot. But the biggest difference from my reading, at least, is that in sclerema neonatorum, you get these nodules that begin to make diffuse, firm, expanding plaques that are really firm and hard and waxy and feel kind of tethered and hooked onto the fascia, like they're not mobile nodules. So clinically it presents differently. Rather than bilateral nodules over bony prominences, you get these thick, waxy induration that spreads. And so I think that's the big difference. But that disease is very bad and is often fatal. So it's an important distinction to make. But I have never seen a case of sclerema neonates harm in practice. But it's one of those things that I always worry about and wonder how to tell apart. And that's what, from my reading last night, that's what it says. So